participants for today's afternoon program of clinical case discussion of interesting cases. Today we have 4 cases for discussion in total. First case, a rare case report of tubercular perforation of ileum from Department of General Surgery, a diagnostic odyssey, shadow at left hilum, Department of Respiratory Medicine, the silent eroder, a case of extensive cholesteatoma from Department of ENT, Vellich's encephalopathy from Department of Urology. So we'll start with the first case, a rare case report of tubercular perforation of ileum from Department of General Surgery, presented by Dr. R. Chandi Priyanka, Junior Resident General Surgery. The case will be moderated by Dr. Raja Babu Sir, General Surgery.
General Surgery Department. My moderator is Dr. R. Rajbabu Sir, Professor of Department of General Surgery. Today my topic of discussion is a rare case report of tubercular perforation of ileum. Patient profile: a 19-year-old male presented to the emergency room on 4th April 2026 at 10 a.m. Chief complaints of fever since 5 days, abdominal pain since 3 days. History of present illness: patient was apparently normal 5 days prior to the presentation. Developed fever, which is sudden in onset, high grade, continuous with chills and dry gas. Admitted to an outside hospital for the same and subsequently discharged. Concurrent workup at outside hospital. Evaluated for fever with pedal edema 5 days prior. Diagnosed with dilated cardiomyopathy, which is mild MR, mild TR with PAH with ejection fraction of 40%. Lower abdominal pain since 3 days, sudden in onset, continuous throbbing type, progressive to diffuse abdominal pain associated with abdominal distension since 1 day. 1 episode of vomiting, non-projected, non-bilious, not bloodstained, obstipation since 2 days. Past history: known case of seasonal asthma since 5 years. No history of similar complaint in the past. History of anorexia and weight loss for the past few months. Personal history: patient takes mixed diet, altered bowel.
Any comments on that history of asthma and drug treatment in our readout? What is taking for the seasonal asthma? No drugs or only?
No drugs. No drugs. He is not taking any medications.
You are not eliciting. It cannot happen 5 years after asthmatic not taking drugs. Okay. Because that has bearing in the outcome. You would have elicited that history.
Weight is 40 kgs at the time of. Sir, his weight is 40 kgs, sir. Previously he was 50 kgs, sir. He lost weight at 10 kgs in past 6 months, sir. Yes.
That becomes scientific.
Yes.
It is an unscientific statement.
Yes. Yes.
No. What is the rationality of writing absolute values of weight loss and time? Beside
5% of weight loss in months or 10%
percent of body weight. Right. Therefore, you have to mention history of anorexia, weight loss, for significant weight loss. The word when used it is scientific. By 20 kg in 6 months or 60, that is 1/3, 30% weight loss. The moment significant weight loss, it is a disease, nothing else. Disease is called significant weight loss.
Personal history: patient takes mixed diet with altered bowel and bladder habit, recurrent constipation and diarrhea for 2 months, altered sleep and appetite, no history of addictions or allergies. General physical examination: patient is conscious, coherent, oriented to time, place and person at the time of presentation, thin, built, poorly nourished with weight of 40 kg and BMI of 15, sir. Yes. Bilateral pedal edema noted, pallor present, no icterus, cyanosis, clubbing and lymphadenopathy. Vitals at the time of presentation, Temperature is 99 degrees Fahrenheit. Its pulse rate is at 154 beats per minute. Blood pressure over 100 by 80 millimeters of mercury. Respiratory rate of 26 cycles per minute with SpO2 of 95% on room air. Random blood sugar of 95 milligram per deciliter. Abdominal examination. On inspection, abdomen distended, umbilicus midline and inverted, no visible sinuses, scars, engorged veins or peristalsis. External genitalia appears to be normal. Perineal orifice negative for cough impulse. Sir, any fistula? On examination percussion, tympanic note throughout, labor dullness obliterated, auscultation, bubble sounds not heard. On distal rectal examination, no skin tags, fissures, sinuses or fistula, anal tone normal, rectum is roomy, loaded with soft stools, glove stained with fecal matter. My DDs are perforation peritonitis more towards because of guarding rigidity and obliterated liver dullness and free gas in further X-ray findings. Intestinal obstruction due to distension, obstipation, vomiting raise the possibility of mechanical obstruction. Investigations.
This is a frontal abdominal radiograph showing multiple dilated central bowel lobes, evident by prompt and valvular conjunctivitis. Large abnormal airflow levels seen in hepatic flexure and splenic flexure. There is paucity of gas shadow in peripheral areas of lower abdominal area and absence of rectal gas shadows. All these features are in favor of intestinal obstruction.
No pneumoperitoneum. That is common because their diagnosis is a perforated discus.
Air outlining both sides of walls of small bowel loops, this could be a sign of pneumoperitoneum, or it could be due to overlapping of abdominal vessels.
You as a radiologist comment whether there is pneumoperitoneum or no pneumoperitoneum. You cannot say overlap and all. Or I cannot comment.
This is a slide X-ray, we cannot comment if it's pneumoperitoneum.
There is no definitive pneumoperitoneum. Any comments further?
Best X-ray for the patient whom we are suspecting pneumoperitoneum is erect chest X-ray, where the beam exactly goes to the subdiaphragmatic region. We searched for that. There is no chest X-ray for this patient preoperatively. Secondly, in this pneumoperitoneum may not be very much visible, but we cannot completely exclude, as she pointed out. There are some air which is seen inside and outside, which is a sign of pneumoperitoneum, but the gas can be overlapped by the gas shadow behind the colon loops. So grossly there is no pneumoperitoneum, but any minute pneumoperitoneum cannot be excluded. You have to go for erect.
You like to comment on this, which is extra component of here and let it keep it up.
That can be within
because
the
towards mesentery.
That can be within the bowel.
This is a post-operative frontal chest radiograph showing trachea and midline. Cardiac shadow appears to be normal limits. Cardiac shadow appears within to be normal limits. A non-homogeneous opacity is seen in right upper zone. This could be possible consolidation. Mild blunting of left costophrenic angle seen. Possible left mild pleural effusion.
What, sir? All these are all X-rays are same day. Am I right, sir?
No, sir. Post-operative. Post-operative. Day 1, sir.
Pre-operative and PCP.
No, sir. Post-operative.
No pre-operative chest X-ray. You are right. No. Therefore, suboperative pathology is eliminated. Therefore, it is taken post-operative. No pre-operative chest X-ray.
No. We didn't have enough time to take him to X-rays. Within very short time, we had pushed him to theatre because of his peritonitis.
MSG abdomen and pelvis. Small bowel loops appears abnormally distended and fluid-filled. Moderate to gross ascites with internal echoes. Findings raise suspicion for intestinal perforation or obstruction. CT correlation advised for further characterization. Blood investigation. There is anemia with marked leukocytosis with neutrophilia, with elevated ESR and hyponatremia, mildly deranged renal functions. In liver function test, there is a low Ag ratio with hypoalbuminemia. Emergency surgical decision. Based on the clinical and radiological features of perforation peritonitis, the patient was resuscitated and shifted to the operation room for an emergency exploratory laparotomy by the time of 1 p.m. in 3 hours of admission. Sir. On the day of 3 hours of he admitted at 10 a.m. sir. 3 hours of admission. Yes. Yes. Intraoperative findings. 1500 ml of frank was drained on opening of the peritoneum. Small bowel and the peritoneum studded with multiple tubercles. Sir. You can see multiple tubercles are filled in the small bowel. Omentum inflamed and fibrous, dense interbowel adhesions were present. Perforation site, 2 perforation sites identified in the distal area at 6 inches and 4 inches. Yes, sir. From the ileocecal junction, dissection of the distal ilium segment containing both the perforations were performed. Proximal cut and fashion as the end ileostomy. As in this video, you can see the small bowel is fully studded with multiple tubercles, and 2 perforation sites were noted more proximal to the ileocecal junction. From ileocecal junction, it is at least 4 inches and 6 inches. The cecum is also studded with multiple tubercles, that is the appendix. We have dissected including both the perforation sites and kept the proximal end as the stoma and distal end was closed.
Where did you expect there will be a
Most commonly ileocecal regions are tubercular. Because of presence of Peyer's patches, most of the lymphoid tissue is present in that area. Most common stoma formation, proximal end fashion as the ileostomy. As we can see, multiple tubercles are present on that bowel, and the distal end was closed, which was more proximal to the ileocecal junction. Only 3 inches were present. Post-operative management, initially unstable with cardiac dysfunction, dilated cardiomyopathy with the ejection fraction of 40%. Managed in the ICU with IV fluids, antibiotics and supportive care. Antitubercular therapy initiated on POD 0 in view of intraoperative findings. Nutritional support progressed from total parenteral nutrition to liquids, followed by the soft diet. Wound adhesions at the laparotomy site, which has healing with secondary intention. Gradual stabilization over the following days.
Is he alcoholic?
No, sir. CB-net, peritoneal fluid CB-net positive for Mycobacterium tuberculosis.
The focus photomicrograph shows intestinal mucosa lined by columnar epithelium showing ulceration. The underlying lambda propria shows inflammatory cells, mixed inflammatory cells consisting of lymphocytes and neutrophils. This is high power image showing a well-formed granulomas with a Langhans type of chain cell. The histological features are suggestive of K-shaped granulomatous
I'm not
inflammation.
able to see anything. You show once.
Langhans type of chain cells. This is having multiple.
What's the focal magnification?
This is
What's your magnification?
a low power image. Sir.
How do I know it? Unless you mention it. At the right hand corner or the left hand corner you will
The
write
left side is
magnification
a low power
in a
image.
pathological slide. In a pathological pathology slide when you project it, where you write magnification, top, down, right or left. Must learn all the things. Okay. Which is high power in this? This side, right side?
Left side.
Left. They are showing the Langhans that is like
This is high power side.
clear way.
This is the area of caseation. And these are the Langhans type of chain cells. This is the classical case of intestinal tuberculosis. Lastly, also tubercles are seen on the dissected specimen, and microscopically also there were multiple caseating granulomas and large areas of confluent caseous necrosis. So microscopically it is a straightforward case of intestinal tuberculosis.
Lymphocytes. Why they are attracted by the lymphocytes? Lymphatic tissue, right? What is the prevalence? It's because of the lymphatic tissue. Usually the occurrence and the damage and perforation occurs in the area. Why is that? But the lymphatic tissue everywhere does it.
The question is why ileum is terminal ileum is fascinatingly the destination for the people. That is the question simplicity.
When we come back and we're not doing that.
But it took
Like to comment or any pulmonology?
why is the special favoritism to the going there and destroying only in the ileum? 1 in 10%.
You want me to answer, sir? If you recollect your lymphoid tissue aggregation in the development of midgut, from that of duodenum to that of ileum, it progressively enriches towards the terminal component because it has to make the terminal ileum and cecal junction as a sterile component of the entire intestine. Therefore, the patches of lymphoid aggregations, Pierce patches and other lymphoid component is massively present in terms of last part of the intestines for ileum rather than jejunum. Therefore, the transit time also in jejunum to the ileum becomes more and more. Therefore, ingested tuberculous bacilli landing in ileum to the top colon, ileocecal, is much longer. Once upon a time, when there is no bacillization, bovine tuberculosis is one of the commonest cause for ileocecal tuberculosis once upon a time. But now, it is It is towards real non-covalent because of path radiation. Even that, it is at the highest concentration of lymphoid because tuberculosis organism doesn't fight with the body. They make the immune system first friendship, then subservient, then it is mass production. 3 stages for tuberculosis. Stage 1, the tuberculosis organism makes friendship with the immune system. Stage 2, it tries to give way to the immune system. Stage 3, it controls the immune system in what fashion it likes. The result may be anything of inflammation. That is not my last 3 years back. The revisited pathogenesis of tuberculosis. Tuberculosis organism controls the vibrinal apparatus at will and pleasure. Not you control the tuberculosis organism. That's why we can never eradicate tuberculosis. And the most important point is you finish. Then we will talk with the help of the
Histopathology report draws multiple perforations and ulceration, ulcers with loss of mucosal folds, microscopy, transmural ulceration with caseous necrosis, granulomas and Langhans drain cells and inflammatory infiltrates, impression, caseating granulomatoous inflammation consistent with intestinal tuberculosis. Clinical outcome, gradual clinical improvement with weight gain of about 5 kg in 3 months. Functional ileostomy, continuation of ATT, plan to restore intestinal continuity after completion of ATT and reassessment. Our take-home message: in India, abdominal TB is a great mimicker, diagnosed early with high index of suspicion, coordinated multidisciplinary resuscitation and prompt source control, reserve surgery for complications such as perforation, obstruction or hemorrhage. Intestinal obstruction is the most common surgical complication of abdominal tuberculosis. However, our patient presented with intestinal perforation, a rare presentation, treated primarily with anti-tubercular therapy.
Dr. Rajbab, Professor, will make some comments.
10% only, sir.
Commonly, the surgical part of intestinal tuberculosis, we see obstruction, either as multiple stricture, single stricture, or as a mass. Intestinal mass itself forming an obstruction. But rarely do we see, as you said, about 3 to 7% perforation. In this case, he was a young guy who came with tachycardia, tachypnea, a bad shape of 5 days duration, had a florid perforation and bioperitoneum. So we have to take him in, and there was no chance of doing any anastomosis. Number 1, hypoproteinemia, anemia, and the bioperitoneum itself. Hence we did the ileostomy, and I would like to thank the other team members, multidisciplinary approach, as she said, the anesthetist, the intensivist, nutritionist, cardiologist, Ishwar sir, chipped in with his additive therapy advice, the respiratory medicine. Actually, it was a multidisciplinary system in the whole hospital which helps save the patient.
What happened ultimately? What is the problem? Can you close it now before the completion of the class? Why not?
Because
the disease is still active.
At that point of anastomosis, when you close it, that it becomes a tuberculoma. And ultimately, after a long time, a cell is stuck. But originally, it is later. Any questions from the pulmonology side with reference to this? Because perforation of viscous of tuberculosis denotes total surrender to the tuberculosis. There is no immune reaction. That's what occurred. Normally, tuberculosis elicits immune reaction, fibrosis, radiations, mass formation, and all. But never, very rare. That means itself is nutritionally got nutrition. And a comment on the side with reference to cardiomyopathy fraction, as it will be covered in your next thing. Not do that. Why? Because is it malnutrition related component of cardiac dysfunction associated vitamin, or it cannot be tuberculosis because there is no artificial. That should be documented. Therefore, you need another. Any comments of disseminated tuberculosis and cardiac dysfunction? Because it is reversible toxicity.
My moderate rate.
The question now is the lung tuberculosis but the lung component is too small, not having a capacity to even cough. Therefore, it is a post-primary advanced, what is called post-primary metastatic, or otherwise known as disseminated tuberculosis, landing on the rather than post-cough and other associated.
Good afternoon, everyone. A diagnostic. I am Dr.Pinnamaneni, second year resident, Department of Respiratory Medicine. My moderate is Dr. SIMS, senior resident. My topic is a diagnostic OIC, a shadow at the left high lung. A 70-year-old male patient, resident of Gannavaram, farmer by occupation, came to the hospital with the chief complaints of shortness of breath since 15 days. History of present illness. Shortness of breath since 15 days, which is insidious onset, is initially grade 2, gradually progresses to grade 3, which is according to MMRC grading, aggravated on exertion, relieved on rest, with no postural and no diurnal variation, not associated with wheeze, orthopnea, PND, and palpitations. No complaining of cough, expectoration, hemoptysis, and chest pain. No complaining of fever, evening rise of temperature, pedal edema, or decreased urine output, and no loss of appetite and no loss of weight. Past history. No history of similar complaints in the past. He is a known case of hypertension and type 2 diabetes mellitus since 25 years. He is on regularly on medication with tablet metoprolol 15 mg, metformin 500 mg BD, tablet glimepiride 2 mg BD. History of COVID-19 in 2020, which is managed at home. No history of PTD, coronary artery disease, cardiovascular accident or hypothyroidism, COPD, bronchial asthma, and chronic kidney disease. He has a history of allergic manifestation to cold and dust since 5 years. No history of inhaler usage. Personal history. Patient takes mixed diet, sleep adequate, and appetite decreases since 15 days only. Bowel and bladder habits are regular. He is an ex-smoker, stopped 2 years ago, which is 20 cigarettes per day for around 40 years. Smoking index is 800. And back years are 40. Family history is very significant. General physical examination. Patient is conscious, coherent, and cooperative, oriented to time, place, and person. His BMI is 33 kg per meter square, comes under obese class 1. No pallor, icterus, cyanosis, burping, generalized lymphadenopathy, and no edema. Vitals on the day of admission. Temperature is abnormal, pulse rate is 92 beats per minute. Regular in rate, rhythm, character, and volume. No radiolateral and radiofemoral delay. No abdominal vessel wall thickening. All femoral pulses are felt. Respiratory rate is 20 cycles per minute. Abdominal thoracic breathing, and no accessory muscle usage. Blood pressure is 120 by 90 mm of HG in the right arm in sitting position. Saturation is 99% at room weight. In systemic examination, upper respiratory tract nose is right-sided DNS and there are no polyps. Oral cavity is nicotine stained teeth are present, dental caries, and no loosening of tooth and poor oral hygiene. Lower respiratory system. On inspection, shape of the chest is elliptical, symmetry is bilateral symmetrical, chest movements appears to be equal on both sides, trachea appears to be in midline, apex teeth is not visible, no visible engorged veins, scars, or sciences. No spinocerebellar abnormalities. On palpation, all respiratory findings are confirmed. No local rise of temperature or tenderness. Trachea is in midline. Chest wall movements equal on both sides. Epical impulse is in left fifth intercostal space, half inch medial to mid-clavicular line. Vocal frequency is decreased in left infraclavicular area. On percussion, direct percussion, bilateral clavicles are resonant. Sternum upper 2/3 is resonant and lower 1/3 is dull. Indirect percussion, intake node is edged at left infraclavicular area. Chronic isthmus is bilaterally resonant
Right heart border is corresponds to the right sternal border. Left heart border is half inch medial to the mid-clavicular line in left fifth intercostal space. Liver talus is inserted in the right fifth intercostal area, and tidal percussion is inserted in the right sixth intercostal area. Transportation, right respiratory system, right normal vesicular breath sounds present. Decreased breath sounds in the left infraclavicular area. Bilateral occasional expiratory release is present. Vocal resonance is decreased in the left infraclavicular area. Cardiovascular system, S1 and S2 heard, no murmurs. Gastrointestinal system, soft, non-tender, and no organomegaly. Central nervous system, no vocal neurological deficiencies. By provisional diagnosis is the left upper lobe mass lesion with acute exacerbation of COPD with the type 2 diabetes mellitus with the hypertension. Chest X-ray on the day of admission.
So fast chest radiograph showing a homogeneous soft tissue density opacity located superior to the left hilum toward broad-based toward the mediastinum. Aortic outline is well outlined. This might exclude vascular lesions such as aneurysm. Left costophrenic angle is hazy. This could be due to overlying soft tissue shadow or mild pleural effusion. The lesion could arise from mediastinum or from aortopulmonary window. Differentials include any pathological mass of neoplastic etiology or a pathological lymph node right now appears.
This is the standard 1 lead ECG. Shows ectopics in the sleep second lead. On the day of admission, investigations were total leukocyte count was 16,800. Remaining parameters were normal. So the prevention was treated with injections of paracetamol and sulbactam, clarithromycin, and acidophilin, nebulition with formoterol and glucosinide, tablet icosprin, tablet bisoprolol, tablet enigliptin, tablet metformin and glimepiride, and 1 pint of NS with MBA. 2D echo was ectopics noted during the study. No left ventricular regional valve motion abnormality, good LV function, ejection factor is 60%. Mild concentric left ventricular hypertrophy, still no diabetic valve, grade 1 left ventricular diastolic dysfunction, no MR, TR or PAH, no PE or quad vestation. IVC is normal and collapsing. We sent for sputum for examination. The sputum CV net was negative. On the microscopy, it is negative for acid for bacilli, and there are few gram-positive pocket in pairs, and some gram-negative bacilli are also seen. Sputum culture was Pseudomonas aeruginosa, which is sensitive for imipenem, meropenem, ceftazidime, piperacillin and tazobactam, ciprofloxacin, cefepime, polymyxin B, and sulfarazone sulfate. USD abdomen and pelvis was done. Impression was polylithiasis and simple left venosis. Due to mass suspecting the mass in the left hyoid, so we have screened matters.
These are limited axial sections of CSP chest showing a relatively defined soft tissue density, lobe-rated mass, epicentered in the anterior and epicostal segments of left lung. This is seen abutting the mediastinum and also encasing the segmental arteries, like the epicostal and anterior segmental arteries. And some homogeneous enhancing lymph nodes were also seen. So with this vascular encasement and homogeneous enhancement of mass, this mass would property of a neoplastic etiology than infection.
Shows anterior segment of upper lobe homogeneous post-contrast enhancement, which is showing neoplastic etiology. So that we have underwent CT guided maps, which is sent for histopathology.
This is a representative photomicrograph submitted. So here we can see in the scanner view a tumor tissue with adjacent pseudostratified ciliated columnar epithelium, and under low power we can see the tumor arranged in sheets and islands. This is a high power image where we can see the pleomorphic cells showing eosinophilic cytoplasm and variants of necrosis because there is absence of keratin pulp formation and no intercellular bridges noted. Histomicroscopic picture suggests poorly differentiated squamous cell carcinoma.
The final diagnosis was left upper lobe poorly differentiated squamous cell carcinoma with type 2 diabetes mellitus with hypertension. With the node was given, node was more than 7 centimeters. That's why we stage as T4, and there is no PECT. See, the PET CT is there, so that's why we make it T4 and 0 and 0. Patient was referred to oncology center for further medication. And discussion: patients with lung cancer may be asymptomatic in up to 50% of the cases. Cough and dyspnea are rather non-specific symptoms. Squamous cell carcinoma is usually centrally located, strongly associated with smoking, often presenting with cough, epilepsis, and obstructive pneumonia. In this current scenario, patient presented with non-significant breathlessness with no other systemic manifestations. This highlights the need of thorough evaluation and multimodality approach in high-risk group. As per GOLD 2025 guidelines, routine screening for malignancy in high-risk group like under age with heavy smoking history more than 25 years and warning symptoms like dyspnea, chronic cough, and expectoration is advised.
In this patient, the history is very short. Whether the history is correlating with the mass lesion or unrelated.
Unrelated. Actually, this patient came for a cardiac checkup, routine checkup. So they referred to the pulmonology for respiratory system screening.
This breathlessness of short duration derivation is cardiac in origin, or pulmonary origin, or nothing in origin.
So incidental finding or
incidental finding.
So there is an exciting.
Yeah, but this is a short duration symptom. Both are really vital. It's a rapid symptom.
Evaluation of breathlessness, and on presentation patient was complaining on breathlessness. When we got to get chest X-ray, we find hilar mass, and then after further evaluation, we got to know it's malignancy.
The question is sudden deterioration and increasing breathlessness. Are they related to your department or their department? Incidentally found out the mass. The mass can explain it or not. That is my question. Right person, not my question. I don't question it.
This breathlessness is non-significant.
Because there is some amount of an acute onset of lower lobe of the left lung, damage of volume is lost. Probably the mass are engulfed and beyond, and therefore partial atelectasis.
Breathlessness is grade 3.
Yes, sir. He is already having elderly individual and cardiac, diabetes, hypertension, and on that a little amount of diminished ventilator component by partial collapse is sufficient to aggravate the blood pressure. Or by pulmonary, I don't know, pulmonary was commented in the CT. Pulmonary, any involvement in the CT? Because they said that is coming and there is some amount of no involvement in the annual loss.
Next case for discussion, the silent eroder, the case of extensive cholesteatoma from Department of ENT, presented by Dr. Sujan Rachel. Case is moderated by Dr. Vinisha.
Good afternoon, everyone. I am Dr. K. Sujana Rachel, second year postgraduate of the Department of ENT HNS, and today my moderator is Dr. K. Vinisha Ma'am, Assistant Professor of the Department of ENT HNS, and I am presenting the silent eroder, a case on cholecystoma. A 59-year-old male presented to ENT OPD with chief complaint of left ear discharge since childhood. The present complaint of left ear discharge started in his 20s, which was scanty, persistent, foul-smelling, and non-blood stained. The patient had on and off episodes of ear discharge of 15 episodes per year, each episode lasting for 8 to 10 days. There is history of decreased hearing present initially to low whispering sounds, later progressed to complete loss in the left ear, and in right ear it gradually decreased, but he is able to hear loud soft conversations. There is no history of ringing or reeling sensation or any symptoms suggestive of facial nerve weakness. There is no history of trauma to ear or any similar complaints in the opposite ear. There is no history of symptoms suggestive of intracranial complications and no other nose and throat complaints. On clinical examination, the patient was conscious, coherent, cooperative, and well-oriented to time, place, and person. He is moderately built and nourished, and there is no pallor, picturesque, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy. Vitals at the time of examination are the blood pressure recorded as 140/90 millimeters of mercury in right arm on supine position, and the pulse rate is 88 beats per minute, the respiratory rate is 18 cycles per minute, the temperature is 98.6 degrees Fahrenheit, and SpO2 is 99% on room air. The patient had no past ENT surgeries and the family history is not significant. He takes mixed diet and sleep and appetite are normal. The bowel and bladder habits are regular and he is a known smoker since 45 years. On local examination of the right and left ears in the pre- and post-auricular area, there are no scars, sinuses and fistulas. The pinna appears to be normal in the right and left ear, whereas in the right ear, the external auditory canal is normal, whereas in the left ear, it is filled with purulent discharge and it is clear. On clearing, we can see the tympanic membrane. In the right ear, we can see the tympanic membrane is normal with prominent head of Malleus, but in the left ear, we can see that the tympanic membrane is completely draped. We can see that the tympanic membrane is completely draped onto the promontory with a small perforation present anteriorly, and there is a retraction pocket present in the posterior superior quadrant going into the attic. Here we can see only a small part of the handle of Malleus present. And this is the normal canal present in the right ear, whereas in the left ear we can appreciate the erosion of the posterior canal. The tuning fork test, Rini's test. In the right and left ear, 256 and 512 Hz were negative. And in the right ear, 1024 Hz was positive, and in the left ear, it was negative. The Webbers were lateralized to the left ear. The absolute bone conduction test was decreased and examiner on both sides. Functional tests of the right and left ear, the tragus tenderness was absent. In the three-finger test, there was no tenderness elicited, and the fistula test was negative. Examination of nose, there is deviated nasal septum to right, and in the examination of oral cavity or oropharynx, important stained buccal mucosa and teeth are present, otherwise no abnormality was detected. And we have provisionally diagnosed the patient as left chronic otitis media, active squamosal type, severe hearing loss without any complications. For further management, we have advised for audiological and radiological investigations. The Pureton audiometry of the right ear was noted as moderately severe sloping sensory neural hearing loss, and in the left ear it was noted as profound hearing loss. We have ordered for a HRCT temporal bone.
These are axial sections of left temporal bone from caudal to cranial. You can see soft tissue attenuation filling the entire middle ear cavity and also extending to the external auditory canal. In this section, we can see soft tissue attenuation within the middle ear cavity, eroding the ossicles and also in the master cavity. In this section, we can see it's also filling the sinus tympani and facial spaces. In this section, we can see it's extending to the sputum is not clearly visualized, probably eroded. So with this presentation and extensive involvement and erosions, it could be cholesteatoma.
The final diagnosis was left chronic otitis media, active squamosal type with profound hearing loss without any complications, and the patient has been planned for modified radical mastectomy with tympanoplasty. Preoperative profile was done and it is within normal range. This is an illustrative endoscopic picture of the middle ear showing the malleus, incus, the superior tendon and the stapes with the promontory, oval window and the round window with the eustachian tube orifice. Eustachian tube orifice. Now we will see how this case has been presented. A post-auricular incision is given and the tympanomeatal flap is elevated to visualize the middle ear contents, and here we can see the loss of the ossicles present in the middle ear, and then mastoid drilling was done in the mastoid cortex. On deepening the groove, we can see a pearly white structure present over there. Cholesteatoma usually has a pearly white appearance, and here on drilling we can visualize it. On drilling in the attic region, we can see that the sac is coming from the adductus and it is being removed from the adductus, attic and the antrum, and it is being sent for biopsy. The facial bridge is being drilled and removed from the anterior buttress to make a communication from the attic to the middle ear, and the ossicles are missing here, as it is seen only a small part of handle of malleus is present and it is being detached and removed. The facial bridge is being gently lowered as it harbors the facial nerve beneath it. The squamous epithelium is being removed from the second genome of the facial nerve here, and also from the round and oval window, and the round window reflex is being checked here. This is the mastoid created cavity showing the mastoid middle ear and the external ear, and here we can see even the dome of the lateral semicircular canal partially eroded. A small piece of conchal cartilage is being harvested from the patient and it is being placed over the oval window, and the round window reflex is being checked here. The conchal cartilage is being secured with gel foam around it, and a harvested graft, temporal spatial graft is being placed over the cartilage. Neatoplasty is done to widen the canal, and the post-auricular incision is being sutured in 2 layers. This is the preoperative image, endoscopic image showing on the left side, and on the right side we can see the created cavity of the mastoid and its continuation with the external canal. Biopsy of the excised specimen.
This is a focused photomicrograph showing low power view on right side and high power view on left side, showing laminated keratin flakes which are suggestive of cholesteatoma.
And the impression of the report was suggestive of cholesteatoma. Post-operative care, the patient is treated with appropriate antibiotics and analgesics. Daily mastoid dressings were done. External auditory canal pack is changed on POD3. And on POD7, the external auditory pack is removed and suture removal was done. The patient is being discharged in a stable state. Discussion. The term cholesteatoma is a misnomer as it is histologically benign. It is a 3-dimensional epidermal and connective tissue structure, usually present in the form of a sac, conforming to the architecture of various phases of the middle ear, attic and mastoid. It has the capacity of progressive and independent growth at the expense of underlying bone, with a tendency to recur after removal. It is commonly called as skin in wrong place. The hallmark feature of cholesteatoma is its capacity to erode, which is driven by the mechanism of osteoclastic bone resorption, stimulated by inflammatory cytokines, localized pressure, keratin, and bacterial toxins. Complicated cases end up spreading into the inner ear and can involve the facial nerve, posterior fossa dural plate, causing intracranial complications. Early diagnosis and timely surgical intervention are crucial to prevent the progression of the disease and to achieve a safe and dry ear.
Sure, he knows. I had the experience of having cholesterol of the only ENT surgeons get. It is common report.
Therefore, there is a relationship between ENT and the bladder with reference to transitional component coli and inverted papilloma and variants. Any pathology comments? Regular feature.
Regular. So basically, the rarity about this patient is he lost total hearing. So inner is totally dead in this patient. So it's a silent one, but it's not silent as it's totally destroyed. The hearing component.
In the Buddha days, is it called malignant arthritis or long back?
That's different, sir. Diabetic arthritis.
Now the last case, Wernicke's and neurology. Case will be moderated by Dr. Vamsi Krishna, neurologist.
A 46-year-old female, a homemaker, resident of Katredipadu, she presented with complaints of pain, abdomen and vomitings of 20 days duration, for which she was admitted under the Department of General Surgery. After further evaluation, they established the diagnosis of acute appendicitis, and she subsequently underwent laparoscopic appendectomy in the Department of General Surgery. Following the surgery, on post-operative day 2, neurology referral was sought in view of progressive weakness of both lower limbs. Prior to surgery, despite she is having a generalized weakness, she was ambulant with 1% support and was able to perform limited activities. On the second post-operative day, the patient developed worsening of her lower limb weakness. She was then able to walk only with the support of 2%. On the third post-operative day, the patient attended noticed excessive fearfulness, anxiety, sleeplessness and altered behavior, for which psychiatric consultation was taken and treatment was initiated accordingly. However, because of persistent neurological symptoms, she was transferred from the Department of General Surgery to the Department of Neurology for further evaluation. The lower limb weakness progressed to such an extent over a period of 1 day, where initially she was able to walk with 2 people support, and now she was unable to move her limbs in supine position, and it is associated with burning sensation of both feet. Throughout the course of history, there is no history suggestive of fever, recent vaccination, trauma, back pain, constitutional symptoms or recent diarrheal illness. There was no history of visual or diplopia and bulbar symptoms. In the past history, she is a known case of type 2 diabetes mellitus for past 2 years. Previously on oral hypoglycemic agents, but she discontinues 3 months prior to admission. She is a de novo hypothyroid and she was on DAB levothyroxine 25 micrograms once daily. And she is de novo hypertensive. And there is no documented history of previous stroke, seizures, chronic neurological illness, tuberculosis, alcohol intake or prior similar episodes. Personal history, previously she used to take mixed diet, but there is a marked reduction in the oral intake for nearly 20 days, secondary to abdominal pain and vomiting. History of weight loss of approximately 6 kg over 1 month before the present illness. Previously her weight is 55 kg and now her weight is 49 kg. There is more than approximately 10% of her weight gain is there in approximately 1 month. Bowel and bladder habits were regular. She has been markedly disturbed, sleep has been markedly disturbed since the post-operative period. There is no history suggestive of any substance abuse. And her menstrual cycles are regular. And coming to the differential diagnosis, Wernicke's encephalopathy with peripheral neuropathy, with polyneuropathy, secondary to thiamine deficiency, and GVS, which could be precipitated by recent systemic illness or surgery. And the vital signs were BP.
Where is the abdominal pain? Can it be, you think the cause is due to the warm vomits and abdominal pain is due to appendicitis or due to thiamine deficiency? How do you know? Because
is it the autonomic feature of your post-op Guillain-Barré or pre-op, or is it part of neurological component, or is it appendix related? That's the question.
Patient is having vomitings and abdominal pain, sir. That can be seen in appendicitis or
histopathological examination.
That's okay. Histopathology is suggestive of something, but based on the history, can you have any clue that because their entry called gastrointestinal beriberi. See, patient of thiamine deficiency, particularly in non-alcoholic patients, they can have a presentation of vomitings and abdominal pain due to thiamine deficiency also.
My question is now, is he having abdominal pain first or vomitings and then abdominal pain?
Abdominal pain. Abdominal pain first. Vital signs on the POD day 3, blood pressure is 130 by 90 mm of mercury in bilateral upper limbs measured in lying down position. Pulse rate is 122 beats per minute, regular rhythm and normal volume. Respiratory rate is 19 cycles per minute. Temperature is 98.6 Fahrenheit. And SpO2 is 99% on lumen and GRBS is 180. And there is no pallor, icterus, cyanosis, clubbing, significant lymphadenopathy and pedal edema. Serious respiratory and GI systems are normal. And neurological examination on the POD day 3. Her higher mental functions, she was confused with impaired attention and she was not oriented. Cranial nerve examination, no cranial nerve deficits are detected. These cranial nerve examination is normal. And coming to motor system examination, attitude of the patient.
Post-operative and the operative findings and therefore, I put a question. The abdominal pain. That's why I'm coming to it now. An abdominal pain and vomiting. That is very interesting. Because all abdominal pains are not in surgical navigation. Certain abdominal pains which mimic surgeons, but they should not operate it. One among it is our heart area. The other one is diabetic autonomic neuropathic related pseudo diabetic. Good olden days, that is diabetic crisis abdominal pain. Now he had a lower limb weakness. I don't expect a peripheral neuropathy acutely caused lower limb weakness. Therefore, how do you differentiate as a resident between a post-operative lower limb weakness of peripheral neuropathy versus or Guillain-Barré versus your Wernicke's weakness? Simple question.
Post-operative, there will be a definitive sensory loss.
The question itself contains the answer. A post-operative either Guillain-Barré or acute exacerbation of peripheral neuropathy is element, whereas Wernicke's group of primary weakness occurring is a higher level. Yeah. That can be differentiated provided two reasons. Now, go through your motor examination.
To differentiate, but you said dry beriberi versus GB syndrome. What are the other differentiations? Which is apart from
Could be
respiratory. Does it
Because
have any
it is
clue?
lower limb weakness, I will call it as post-operative.
Or you can see both the conditions together.
The weakness is present prior to surgery?
No, there is a slight weakness, sir, but she was somehow ambulant with 1% support.
Weakness is there before surgery also. Yes, that is what.
That I don't know. There's no one has seen that prior. But
How to differentiate GB syndrome versus dry beriberi?
Depending on the other cranial nerve involvement, could be seen in GP syndrome. And the sensory predominant findings could be seen in more in dry beriberi, sir.
Next, one of the most important features are autonomic manifestations are seen in which disease? Not enough. Cranial nerves are more involved.
There is no
And most important differentiating it, dry very won't occur acute. That's subacute.
It's slow, subacute, chronic.
It's not in the day period.
Therefore, dry will not come into the picture. It is a complication, acute of something, and your post-operative Guillain-Barré. Both will have ophthalmic failure, both will have weakness, both will have something. But it is you who have to make a living.
This patient, before the surgery also, patient is weak such a way that he needs support for walking. At the time we don't know.
He is a diabetic, I think so.
Yeah.
I postulate that it is a chronic distal symmetrical lamp-dependent peripheral neuropathy.
Why not diabetic neuropathy? How to differentiate diabetic neuropathy versus very TB syndrome?
Now my question here is, we might have asymptomatic, long fiber, small, distal symmetrical neuropathy. He is not bothered about it, except little weakness is able to maintain well. But this vomitings and then the precipitation surgery, both can present at Guillain-Barré as well as on a background of this. That is what we are taking. And then why I asked the question, persistent vomiting for post-operative can precipitate. But parenteral vomiting, it is there correctly, they had it. But the precipitating factor is vomiting, not the acute.
See, one more differentiating feature is that timing deficiency, like in dry beriberi, this patient is having, like, apart from peripheral nervous system symptoms, they also have central nervous system. Unlike in GPS, we don't see the central nervous system involved. And how do you differentiate diabetic polyneuropathy versus your GB syndrome or dry beriberi? Apart from leaving the central nervous system symptoms.
Duration of
acute to subacute. One more, the most important feature is one should like you remember that any diabetic neuropathy, most of the times it will be a distal sensory neuropathy. They will walk normally. When we see all the diabetic neuropathy, they don't need support. Whenever you see a diabetic neuropathy requiring support, that's an alternative cancer, like other definitions, not diabetic neuropathy. It's very rare they require support. Most of the people will come in what will they do? So that this comes in the last. Or there might be entity called CADP in diabetes. Acute worsening of CADP, that's a different entity.
Any alterations in the sensorium?
Yes. Later.
That is what it. Alterations in sensorium will never occur in Guillain-Barré unless it is complicated by EDM or he had a respiratory paralysis type of symptom. Therefore, as POT is normal, no hypoxia, but still altered sensorium post-operatively progressive. Normally, post-operatively, any altered sensorium delirium comes early and regresses, but this is reversibly progressive. The progressive altered sensorium post-operatively, not regressive, it should be viewed in a different fashion on the background of this weakness.
Coming to motor system examination, attitude of the patient was lying supine in the bed. Both the lower limbs were externally rotated, upper limbs were resting comfortably by the sides on the post-operative delivery. Bulk is bilaterally symmetrical. These are, we can see her legs are externally rotated. It is suggestive of lower limb weakness. If there is a plantar flexion, we can also see plantar flexion.
It is a photograph to be diagnosed. It is called spotter. Bilateral amount of distal photograph. But he is able to manage, that is the person here, and he is unable to manage post-operative. That is the difference.
Motor system examination on POD day 3. There is hypotonia in both the right and left lower limbs, but upper limbs tone is normal. And coming to the power, there is a lower limb power is 2/5 in both lower limbs, and neck flexors and extensors are normal. Trunk muscle, she was able to roll over the bed. And coming to superficial reflexes, corneal, conjunctival, and abdominal reflexes are present, and plantars mute. Deep tendon reflexes are absent.
sensory modalities couldn't be tested because of the sensorial. Next is cerebellar examination. It revealed bilateral right and left limb ataxia is present along with horizontal gaze above bidirectional nystagmus system. This is a video, sir, showing her upper limb ataxia is seen. Left limb is having more ataxia compared to right side. Next, this is a video of a nystagmus. There is a bidirectional gaze above nystagmus, horizontal type of nystagmus. Next, in the background of prolonged poor nutritional intake, prolonged fasting, recent gastrointestinal illness, that is vomits, and recent history of surgery, the clinical diagnosis of Wernicke's encephalopathy was strongly suspected in this case. So she was
before that, you got was suspected on the basis of how many neurological points?
Clinically, she was suspected. Sir, the criteria is fulfilled, sir. Ataxia is there, sir.
There are trials which were advocated by Victor, Ramandi, Odams, and Victor, with authority or a monogram or Wernicke's encephalopathy, won the third or fifth edition of Harrison's editors. They themselves wrote another neurology textbook, Ramandi and Adams textbook. Tried ACP, ataxia, confusion, and ophthalmoplegia. Here there is ataxia and you have documented confusion. Always that confusion will be sent to the psychiatrist in the must. That happens out of 99 out of 100 cases. When it is the first person to confuse both the referral as well as report is that happens here. Then we have to continue. But because you are not in a position to evaluate with the MMS, you cannot say whether it is confusion, other things and all. Therefore, all of the three, on the background of history of long duration of malnutrition, rather than post surgery, and on the presence of a diabetic peripheral distal symmetrical. Now, confirmation test, these are all not confirmation. They are all associated components. Anyhow, radiology is not.
Next, she was immediately started on high dose of intravenous thiamine supplementations.
Which is the easiest way to confirm? It's some Wernicke's is the easiest way to confirm with what?
Response, nystagmus response.
It is the cheapest way to confirm is treatment therapy, not other. There is no other diagnostic component except measurement of thiamine pyrophosphate, which is very difficult, like 1 ppk, and it cannot be done everywhere, only a few laboratories in the world. But radiologically, you can suspect MRI to a great extent, but not the cause.
Sorry, why don't we take always this is the debate when I never saw any improvement case laboratory wise. Why don't we take some some sample in available population before you inject this therapeutic? I mean, a treatment that even the result comes after 3 days, at least we know that confirmatory diagnosis.
Confirmatory diagnosis is never written in any textbooks as a passing remark, even in the best of the nutritional component. One is thiamine pyrophosphate, other one is alpha-catalase of RBCs, which should be estimated, which are very tough and difficult task, and the sampling itself is with fabricated ice, dry with some amount of things, and otherwise leak and nothing comes out. That's why they don't require it.
Wernicke's encephalopathy is a clinical diagnosis.
Yes.
They are
And therapeutic.
rest are only supportive things.
Therapeutic.
After giving thiamine,
The beauty of this case is this is occurred in the non-alcoholic. That is the most important.
There was an improvement in her nystagmus after thiamine supplementation, sir. Subsequently, MRI brain was performed, which demonstrated imaging findings consistent with Wernicke's encephalopathy, thereby supporting.
What was that day we talked, is consistent?
thereby supporting our clinical diagnosis. After giving timing supplementation, we can see there is an improvement in the nystagmus the following day. Next, these are the MRI images.
Before that, what is the way of improvement occurs? Out of the three, which is the first to improve?
Nystagmus is the first to improve. Nystagmus and ophthalmoplegia.
Ataxia. First, nystagmus related ataxia only. Next, last is your confusion state between is plegia.
In between nystagmus and ophthalmoplegia, which will improve first?
Nystagmus.
Whether it's an horizontal nystagmus or vertical nystagmus, which will improve first? See, there are entities first to improve is your palsy. Atelectus palsy, they will improve first, followed by nystagmus.
Horizontal, because it is the lateral rectus nucleus and lateral rectus MLF first is involved in periaqueductal. Am I right, sir? Periaqueductal.
In confusion, which will improve? Suppose the patient presented with you like in confusion, memory disturbance, apathy, all this will only the minor symptoms will improve. That too, but not the major.
Go ahead, madam. Talk now.
This is an agitation flare image of brain showing a hyperintensity along the medial aspect of bilateral thalami and the periaqueductal and mammary bodies. These are diffusion restricted images showing the diffusion at the mammary bodies and along the medial aspects of bilateral thalami and also surrounding the third ventricle. So with these imaging features, the differentials would be any toxic or metabolic encephalopathy, viral encephalitis, or any hypoxic ischemic encephalopathy. But with the history, classical history, it's more of a toxic or metabolic encephalopathy.
That area is last thinkable involved in ischemia. Can you please comment, sir? Give it to your professor.
With the given isolated hypoxia, isolated thalamic involvement in sparing the vascular layer is pretty much rare. So with the history given and then striking, you show that hypothalamic images, they are striking involvement of the hypothalamus structures. Previous section. Yeah, that two paired structures and adjacent tracks is highly suggestive of meningitis in terms of the image.
Therefore, it can start up to from the hypothalamus membrane up to the periaqueductal third ventricle and just enters the fourth ventricle not involved in the
Next, these are routine.
No. Read the report.
Impression is given as interaxial T2 white matter or flare hyperintensities with mild restriction of diffusion seen involving medial aspects of bilateral thalamus around third ventricles, mammillary bodies, tectal plate and periaqueductal plate, and mild enhancement of sulcal spaces in could be due to any cerebral edema, and to consider the possibility of metabolic or toxic encephalopathy, likely Wernicke's encephalopathy.
Wonderful, you have written it. What toxic encephalopathy can mimic Wernicke's? Number one, is female, non-alpha. We quite often see this picture in a passing fashion, except a diligent specialist will detect in another field. Where you see common in this picture?
Everywhere.
In the optics, you will see it, but you will rarely make it and it passes on routine, except for the rarity of otherwise they will pass it on. Because in the morning sickness it is very common and non-alcoholic common cause of diabetes is early morning sickness pregnancy. Hyperemesis ground over, if it persists beyond, suspect something, not pregnancy. Very person.
Next is another routine reading mesh patient, sir. Her hemoglobin is normal and WBC there is a slight leukocytosis. NCV is normal, sir, and RFT and viral serology is negative. And serum electrolytes at the time of admission there is a borderline hyponatremia
and vitamin B12, calcium, phosphorus within normal limits. And she's a hypothyroid with TSH of 18.43 and with free T4 is within normal limits. And HbA1c.
Waterfall component. This is what he responds. He is hypothyroid? Yes or no? What is the TSH?
18.4.
That itself.
Not a known, sir.
Not a known, because she never admitted. She is the background hypothyroid. Why I am questioning that? The hypothyroidism precipitates much more the deficiency in subcellular level. Because thyroxine is one of the important components which is needed for oxidative dephosphorylation coupling, in which the it enters into the escape, that is Krebs cycle escape molecule. It needs tandem pyrophosphate, TPP1 coenzyme 2. Therefore, when hypothyroidism is there, then it may worsen any of these metabolic points.
Why not like NMIST? That features like periventricular lesions could be seen in NMIST.
Peripheral neuropathy like present is not seen.
This is overt hypothyroid, not subclinical, because it is more than 10, and it is 4th generation ASHS. Therefore, anything above 10 is overt. That needs treatment. In the good old days, it is about 25, 3rd generation equipment for us.
LFTs at the time of admission, apart from ALP, everything is normal. 2D echo was normal at the time of admission. USG, abdomen and pelvis, altered hepatic echotection is seen, with appendix is not visual. And histopathology of appendicitis, the post-operative specimen is, histopathology showed features suggestive of acute appendicitis. And NCS was done, sir. NCS showed evidence of sensory motor axonal polyneuropathy of all 4 units. And magnesium, vitamin D, and creatine, magnesium is normal in this. Next, despite initiation of thiamine therapy on the
post.
Yes, negative. Despite initiation of thiamine therapy on the post-operative day 4, the patient developed progressive weakness involving the upper limbs in addition to the lower limb weakness. Functionally, she became unable to hold the glass of water and grip a spoon or feed herself independently. Neurological examination at this stage demonstrated Junger's areflexia involving all the 4 limbs, raising the possibility of an acute peripheral neuropathic process occurring simultaneously. These are the examination findings of the post-operative day 4, sir. Upper limb power is 3/5 and lower limb power is 2/5. On post-operative day 5, the patient developed visual hallucinations and memory impairment. Investigations revealed hyponatremia and correction was given. Hallucinations gradually resolved with continued thiamine therapy and hyponatremia correction. These are videos showing visual hallucination.
Motor and delirium of hallucination.
Next, following the course in the hospital, the patient continued to have marked impairment of her recent memory. She was unable to retain newly acquired information and she was repeatedly asking the same questions. And she was unable. And she had failed to recall the recent events. She also exhibited confabulations, providing fabricated answers.
Recovered her power.
Power was not recovered.
Not recovered.
She also exhibited confabulation, providing fabricated answers to fill the gaps in her memory, while her level of consciousness remained normal. And after her consciousness improved, upper limb ataxia slightly improved, and cognitive functions including attention, orientation, and memory demonstrated gradual recovery. After regaining in her confusion, we have done cognitive examinations, Edinburgh cognitive examination. In which memory is markedly impaired and fluency is mildly impaired. And attention, language, and visual facial functions are preserved.
And coming to summary, sir, this is a case of 46-year-old homemaker, known case of type 2 diabetes mellitus and de novo hypertension and de novo hypothyroidism, who developed acute appendicitis, subsequently underwent NAP appendectomy. In the post-operative period, she developed progressive worsening of the lower limb weakness, followed by altered behavior, confusion, fearfulness, insomnia, bidirectional gaze, evoked nystagmus, and upper limb ataxia. Considering the background of prolonged nutritional deficiency, weight loss, vomiting, sneeze and surgery, Wernicke's encephalopathy was suspected clinically and IV thiamine was started. MRI brain features are suggestive of Wernicke's encephalopathy. During the course of hospitalization, lab investigation revealed hyponatremia, which could have aggravated her altered mental status. Appropriate sodium correction was initiated and in parallel with ongoing neurological management. Patient was managed with high-dose parenteral thiamine supplementation and correction of serum sodium and supportive care. These are her blood investigations with CBP, which is within normal limits, and her serum sodium levels. There is a hyponatremia and correction of hyponatremia is there.
Cause of hyponatremia in this patient?
Initially, she was on diuretics, sir. Hydrochlorothiazide was.
How long she is on chlorothiazide? After admission or before?
Initially, her sodium levels were normal, sir.
My question is how long she is on thiazide diet?
After admission, she was.
That is hardly 1 week. 1 week hardly will not produce sodium hyponatremia. But a thiazide can produce hyponatremia in this case whenever there is uncorrected hypothyroidism. Hypothyroidism uncorrected can lead to hyponatremia wherever the cause whatever. In other words, hyponatremia apparently occurring for no reason suspected subclinical hypothyroidism.
Will it be like CRT, SIDH, when hypothyroidism?
All criteria of SID is meeting, sir, but her thyroid levels, hypothyroidism is against.
Can it be like a hypothalamic syndrome due to like very hypothalamic syndrome? What is hypothalamic syndrome?
Due to very there will be hypothalamus.
Because there are changes in your thalami or these things that cause hyponatremia.
Next, serum NMOSD and MOG were done, sir, and we have negative. The test spread for serum osmolarity, which is decreased.
Serum osmolarity is dilute, urine osmolarity is concentrated. It means kidney is absorbing water. Serum osmolarity is dilute means there is more water in the body, it has to be excreted. But kidney is not excreted, so it's inappropriately absorbing. It's inappropriate.
Water is retained, sodium is excreted.
Inappropriate ADH. Since hypothyroidism is there, it is because of hypothyroidism. Hypothyroidism was not there, it is a
Next is a ECG, 12 standardized ECG showing normal sinus rhythm, and her rate is around 90 beats per minute. Chest X-ray.
What the present position of the individual?
This is a front chest radiograph with trachea median, bilateral lung fields appear clear, cardiac shadow is within normal limits, both zones of diaphragm are well out. Next, her ALL profile is negative and anti-TPO is negative, CSF analysis within normal limits. And coming to final diagnosis, non-alcoholic Wernicke's-Korsakoff syndrome, dry beriberi, acute symptomatic hyponatremia, de novo hypothyroidism and hypertension, known case of type 2 diabetes, and status post laparoscopic appendectomy. Treatment given, she was started on thiamine supplementation, thyroid supplementation, telmisartan, cilnidipine, metoprolol, and gabapentin. She was treated symptomatically.
Now the professor of neurology will summarize the events of these things.
By the time we take the case, we see that lower limb power is 3/5, upper limb is around 4/5. For the surgery, so the one most important thing one should learn from this case is that persistent vomitings or any malnutrition, even non-alcoholic, like in pre-op also, we should give time and treatment. because the surgery can trigger like an underlying also. Coming to this patient, even though we treated with like a high dose supplementation, the disease progresses. The cause might be delayed initiation of treatment because the 1 month, because the half-life of thiamine is only 20 days, not in details is showing 18 days to 20 days. The person is having vomitings more than 20 days. I don't think thiamine results will be there. The treatment is delayed in this patient. So whatever the natural history for this patient would be like neuropathy symptoms could improve partially, but the brain symptoms, like she is having that memory disturbances and confabulation, that indicates like in Korsakoff psychosis, which may not improve because the Korsakoff syndrome, of course, there is a chronic in this patient, progresses very rapidly. The day normally we say chronic. Korsakoff psychosis is chronic and like irreversible.
Subclinical severe superficial depression, an acute precipitation of insult resulting in vernitis, which recover. The hidden coruscos under the vernitis doesn't recover, it will be persistent. And she had a diabetes spectral neuropathy of foot drop, which is present forever, which I don't expect it to recover. The only component related to vernitis and other ones with nystagmus and lymphataxia. Those three important points point out an acute vernitis component. The chronic vernitis component
takes time to improve. They can improve partial improvement with that. The problem is once the Korsakoff psychosis sets in, whatever the symptoms will there, they won't improve. Korsakoff psychosis,
including neurological component,
everything they won't improve. So whatever you treatment give the before the sets in, like in Korsakoff, so the prevention is better in these patients. Only we can treat the symptoms of vernitis. Like this patient also, there is improvement that vernitis symptoms like confusion and like we documented nystagmus, there is an improvement. They can improve mild attacks, but cognitive symptoms, like in particularly the memory disturbances, the confabulation, anterograde amnesia, difficult improvements.
That point totally excludes post-operative Guillain-Barré. Guillain-Barré will not have an MRI finding suggest of this, including redem. And the other component is the Korsakoff size, it is part.
Regarding the replacement, we have empirically. I'm just wondering out of curiosity, what are the speaking other companies see in the oil gas and
given all not so we covered all the other even we replaced B12 in this patient.
Last one question, when diabetes is concerned, treated with insulin and dextrose. No.
Sugar cells are borderline.
4.4.
Sir, HbA1c 4.4, sir. We stopped then.
Then why are you labeled as diabetic? That means
4.4 is it, sir. HbA1c is 4.4. No history of diabetic, but once we investigate this patient, there is no diabetes. Wait, follow up still she is in body parity. 2 months, 3 months follow.
1 month, April.
1 month.
I have put her on coagulation prophylaxis, anticoagulant. She is walking or standing?
Not walking.
Same, sir. Status quo.
No, she is moving or not at all. Great.
She can move limbs, sir.
Because if they are not moving, why oral anticoagulant will not buy. Therefore, the lesson is persistent vomiting in any surgical scenario beyond 48 hours supplement. This is one of the components which
any patient like malnutrition, alcoholic, always you should give
in the background of a diabetes or any other reason. Otherwise, you will go for the irreversible component of Korsakoff psychosis. As per the original documentation of Pinnamaneni is vernitis center plus 1 gram. The vernitis, if it is treated much earlier, we will have total recovery of ACP, that is ataxia, confabulation, and ophthalmoplegia. The delay beyond that, we will have ACP, C will be left off, that is confabulation of Korsakoff, from which they don't recover because it is related to mammillary body dysfunction and other complications. Any more questions? This is a treatable, very severe neurological disease which comes up therapeutically in a flying color. provided we initiate very early, but not up to 1 week time. Because he has got neurological changes up to the fourth ventricle upper part, third ventricle and fourth ventricle. Good. Announcement, any questions?
No, only one timing deficiency going on there, right? Also, it comes under, that's what it's very, very. No. There is no diabetes in this.
Excellent.
Yeah.
Diabetes is not established.
Patient at the time the Korsakoff cycle sets in, when they have peripheral neuropathic progress, the same nerve, central and peripheral nerve. Just started late.
She is not found to be diabetic.